Dear Chair, dear audience, I would like to present my PhD thesis about biotechnological improvements in clinical hemato-oncology. My name is Ádám Szilágyi, I'm a biotechnologist, and together with my supervisor Miklós Garami and my SMS Mark Hanatfi, we would like to analyze the utilization of chimeric antigen receptor CAR T-cell therapy in hematological malignancies. With these two projects. Firstly, we compared CAR T-cell with standard care treatments regarding efficacy and safety outcomes in a systematic review and meta-analysis. So why is this topic important? As you can see on my slide, in non-Hodgkin lymphoma or acute lymphocytic leukemia and multiple myeloma, the survival rates are still not acceptable. Additionally, in oncology generally, we see that the first few lines of treatments are not successful in the patients. So some patients. So in general, research is starving for novel approaches, and chimeric antigen receptor T cells, or CAR T cells, already shown successes in blood cancers. So we would like to identify the clinical benefits of utilizing CAR T cell therapy compared to the current used treatments in these cancers. So to answer our clinical questions, we used the PICO framework to compare interventional CAR T with standard care or physician's choice cohorts regarding response, survival outcomes, and safety determined with CTC-EA graded adverse event numbers. Our hypothesis was that CAR T cell will increase efficacy and safety in these cancers compared to the controls. So after conducting a systematic search in 3 different databases with the attached search key, we were able to select 28,000 hits, and we were able to work with 48 eligible full texts in the end. But let me stop for a question before deep diving into the results. Actually, where would you start measuring the efficacy of CAR T cell? For example, after the apheresis, for example, after a randomization, or when we actually infuse the CAR T cells for the patient. Both of these approaches are relevant, so we distributed our results into 4 different efficacy analysis approaches regarding the beginning of the follow-up and the study design. So firstly, I would like to talk about non-Hodgkin lymphoma, overall survival, measured with hazard ratio, in an approach of enrolled adjusted outcomes, which means that this pool will contain some randomized control trials too, because we start from the apheresis. So hazard ratio is favoring CAR T cell if it's lower than 1, and we have 0.61 HR here, which is also statistically significant, and the heterogeneity was moderate. And actually, we discussed the clinically meaningless effect between 0.8 and 1.25 with this green line in our forest plots. And the conclusion of this forest plot is that CAR T cell recipients had longer survival and fewer events of mortality. So, if we summarize the different approaches and the subgroups regarding overall survival in Hodgkin lymphoma, we can see that whether how we approach the overall survival, CAR T cell recipients will have better overall survivals in non-Hodgkin lymphoma, except for some subgroups. What about safety? So firstly, we measure safety with odds ratio here, which is also favoring CAR T cell if it's lower than 1. Well, firstly, if we see any number of adverse events in any grade and high grade, both of them we see there's no clinically relevant difference and statistically no difference between the 2 groups. Additionally, thrombocytopenia and high-grade febrile neutropenia decreased with CAR T cell, but hypotension very much increased with CAR T cell, which could be related to the cytokine release syndrome adverse event related to CAR T. Plus, infection numbers that were also not significantly different in our analysis, not even with the mortal infections, which together this safety profile compared to the standard care seems to be similar, and together with the increased efficacy seems to be beneficial. So, since I'm talking to a pediatrician audience, I have to mention the overall survival with acute lymphocytic leukemia too. You can see even better HRs for CAR-T in this summarization with results of 0.30, 0.33, 36 etc. So this suggests that CAR-T cell is superior to the current standard care in leukemia patients. So additionally, which is interesting, I want to show you an interesting result about high-grade graft versus host disease, GVHD, after CAR-T versus controls. So GVHD is an adverse event of transplantation. However, it can occur after the transplantation during the first few lines. And but with CAR-T cell, we saw a statistically significant decrease regarding this event, which supports the idea to use CAR-T cell sequenced together with transplantation in leukemia. And just one sentence about the multiple myeloma safety. Well, we see a tendency of higher number of adverse events with CAR-T cell, but these are not statistically significant except for nausea any grade adverse event numbers. So we need more data on that because, as you can see, it's not that detailed as the non-Hodgkin lymphoma results. But currently, this shows a similar safety profile as the standard care controls. So we were able to provide a well-distributed, comprehensive study in 3 different cancer types, but unfortunately we had shorter follow-ups and slightly detailed control cohorts, and this is actually our clinical implication that we would need more detailed comparison studies for further research. But our conclusion says that CAR-T cell therapy increases efficacy and similarly safe as standard care in patients with hematological malignancies. And we would like to submit this study next in the Journal of Hematology and Oncology. So just a few sentences about my second project plans. This is also going to be a systematic review meta-analysis about the long-term effects of CAR-T cell treatment in hematological malignancies. After what we learned from the first project, we would like to actually further analyze, for example, treatment-specific toxicities of CAR-T cell, longer survival, relapse rates. So this is why we will extract single-arm results after 5 years to define the long-term risk versus benefit of using CAR-T cell in different patient groups. So our hypothesis will say that CAR-T cell will be still beneficial after 5 years regarding efficacy and safety, and currently we are at the prosper registration phase on this project. So this is the 2 studies which I would like to add to the science during my PhD, and I'm planning to attend many international programs in the future. And thank you very much for your kind attention.
Congratulations on your nice presentation. I saw on your first forest plot that about the control treatment, you have 2 types, the conventional and the standard treatment. And I'm not that familiar with the oncological treatment, and I was wondering if there is a very important difference between them, or why do you have both of the types?
So actually, we, regarding the efficacy, we had several different subgroups. We subgrouped the studies regarding the control types. We created 5 main control types in control groups in regarding the comprehensive treatment type, and one of them, yes, was the named standard of care, and another one was about the any kind of chemotherapy or transplantation, because because we had not that much well-detailed control types, that this is the actual one kind of treatment that we give to the patient in this study. Well, they are varied very much. For example, they were not restricted to one kind of treatment, and for example, they were physician's choice, and they very varied in different kind of studies. So this is why we created these. But on the first study, forest plot, we couldn't do subgroup analysis on that.
Thank you.
Then I go on. Maybe I missed it, but I was not entirely sure which age groups or which age distribution you analyzed and which disease stages of ALL.
All of our studies, which we screened and found, there wasn't any age distributions. There was characteristics like older patients regarding non-Hodgkin lymphoma and multiple myeloma, but younger patients regarding leukemia, but they weren't studying separately different characteristics of age groups. This is what we actually are looking forward in the second project, that we will be able to provide data regarding these characteristics.
And the second question regarding disease stage. So is this harmonized across the studies you analyzed? Was it refractory ALL or?
These every patient received some kind of treatment before. These were all of them RR. So yes, definitely in multiple myeloma, they were only RR patients.
Okay, thank you. And were there any other measures, like especially in ALL, like liquid biopsy, PCR, like MRD, that was implemented in some of the studies that you could also look into?
Well, in meta-analysis, we couldn't work with this. Some studies were providing data on that, for example, platelet count and things like that. But unfortunately, in this review, we couldn't interpret these outcomes.
Thank you. Was there a hand? No, then I did misinterpret it.
What do we know about the mechanism? So what is the cytokine profile of these patients after the CAR-T therapy? Or do we know any animal experiments when the ALL models are established and CAR-T therapy is employed? What do we know? Mainly about cytokine signals.
Can you please repeat the question?
Okay. So what is the cytokine profile effect of the CAR-T therapy in human and in animal models?
From this current research, we also couldn't determine that. Some retrospective, some randomized control studies compare, for example, the different molecular basis things about these CAR-T cells, and compare the different survivals. But this is also a CAR versus CAR comparison. We only had to focus currently on the CAR versus different treatments, and currently we cannot interpret it. But after, in the second project, we will answer these questions.
Thank you for your presentation. For this figure and also the other figures, I have seen that there are unadjusted and adjusted hazard ratios. Can you tell me first what's the difference, and second, what are they adjusted for?
Okay, so, well, I want to start with the second question because a lot of things, there are a lot of different adjusting methods used. This is what actually our first problem that we face, that there are so many different methods and what's good, what's not. And well, regarding study design, well, the original studies, were they using unadjusted data, for example, retrospective cohort, or were they using adjusted data? Again, for a retrospective, for example, matched controls or weighted studies. And plus, we added the retrospective studies too into this group, because the rationale to do, for example, a propensity score matching to further simulate some kind of retrospective, sorry, it's not some kind of randomized scenario, things like that. So this is why there's a rationale to do the adjusted together with the, any kind of adjusted measurement, and the unadjusted were not use any kind of statistical methods to do that.
Thank you.
Ádám, do you have any up-to-date information about the general usage of CAR T-cell therapy worldwide? Is it used for research purposes, or it's already implemented in the daily healthcare in a couple of countries?
As far as I know, in the US, thousands of people received already CAR T-cells, and there are many registries going on in Germany and in the US too. And currently there are 5 main randomized control trials going on. But I guess one of them were withdrawn, but we could also all collect these studies into this pool, and they are studying it in glioblastoma in Rome with a success, and in Germany in rheumatology, and these are also successful. So we are looking forward to the forward usage of these, not just in cancers.